All right, well, hello everyone, and I'm really delighted to be here. So I'm going to start sharing my slides and we'll get started. Okay, does that look all right to everybody?
Yes, that looks
Okay,
great.
great. I just want to see if I can do something magical on my screen so I can see you all. Okay. Um, all right, so you see the title of this presentation is Applying a Trauma-Informed Approach to a Physician Health Program. Um, so what I'm going to say today is really meant to build on what you may already be doing at the PHP, or if you're not doing so much of this, to then introduce you to an approach that might be helpful to you. Holly and I have been accepted to do a presentation about this at the annual meeting of the FSPHP in April. And so for that presentation, we're hopeful we're going to be able to report on the successes and the challenges of incorporating a trauma-informed approach to your work. Anecdotes and data in that regard will certainly enhance our presentation's impact on the FSPHP audience. Just a couple of words about the vocabulary I'm going to be using. I'm going to use the generic term clinician to denote any healthcare professional you might be working with. I'm also going to use the general abbreviation of PHP, even though I know not all of you work with the PHP, and also Maryland has a professional rehabilitation program, a PRP. But for simplicity's sake, I'll just be using those terms. All right, let me just tell you a few words about myself and about PBI education. My background is in internal medicine, but I chose to give up clinical practice more than 20 years ago to devote my efforts entirely to ethics, education, research, clinical consultation, hospital ethics committee work, that kind of thing. In 2007, I became introduced to the world of remedial education for clinicians who got in trouble for one reason or another. So ethical issues, professionalism, boundaries, communication, record keeping, prescribing, that sort of thing. I taught for a different remedial course provider for 10 years. I directed their program for 7 of those 10 years, but I came over to PBI in 2017. And PBI has been doing this kind of work of offering remedial courses. We also offer preventive courses, and we've been doing that since 2001. As medical director, I still teach, so I teach ethics, professionalism, boundaries, communication. I facilitate one section of our longitudinal follow-up program. It's called the Maintenance and Accountability Seminars, and that's an extension of the intensive courses that we offer. And then I do a fair amount of public speaking, such as the presentation that Holly and I will be giving next April at the FSPHP. So that's just a little bit about my background. The learning objectives that we submitted to FSPHP are the ones you see here. They differ a little bit from the ones in the outline that Astrid circulated to you previously. But I hope that by the time we're finished today, you'll be able to recognize the link between clinicians' lived experiences, including trauma, and subsequent lapses in professional conduct, substance use disorders, and/or mental health issues. And that you'd be able to describe how a trauma-informed approach to a PHP participant interactions and referrals can improve PHP success in health and well-being outcomes and public safety, and that you'll be able to apply at least some steps that you can take at your organization to implement a trauma-informed approach and utilize trauma-informed referrals. Some of you might find the terms trauma or trauma-informed rather off-putting. Trauma is a pretty strong word. You may think they're even overblown or even scary terms. And if that's how you feel, that's fine. You might find it helpful then to think of this approach as a compassionate approach. However, we are going to discuss trauma quite a lot in this next hour or so. And here's why. Trauma is the lasting emotional response that often results from living through a distressing event. And experiencing a traumatic event can harm a person's sense of safety, sense of self, and ability to regulate emotions and navigate relationships. I love this definition. It comes from the Center for Addiction and Mental Health, which is Canada's largest mental health teaching hospital affiliated with the University of Toronto. There are lots and lots of different definitions of trauma, but I like this because it emphasizes that trauma is an experience, so it's not necessarily a thing, and that it has a lasting effect. And that's one thing I want to highlight with this definition is the enduring fallout of having experienced trauma, as well as the vagueness of the definition. And the vagueness is important, which we're going to talk about in the next few slides. So trauma is really in the eye of the beholder. So an experience that might feel traumatizing to one person doesn't necessarily feel traumatizing to another. And there are two important reasons for that. One is simply because people differ in their temperaments. And what affects one person one way will not necessarily affect another person in the same way. But the more important reason of these two is the social environment of support and bonds. Having a good support network constitutes the single most powerful protection against becoming traumatized by an experience. So if you think about a person going through an experience and it's been upsetting to them, and they feel like they have a community of people who love them and care about them, who they can be honest with, and they can talk about it, they can process it. The person will support them. That person who went through the experience is unlikely to remain traumatized by it for the rest of their lives. And by contrast, if a person goes through an experience that's very distressing or upsetting, and they don't feel like they have anywhere to turn, they don't feel like they have anybody they can go to talk to about it, to get support, to process it. Those are the people who are far more likely to remain traumatized by it over and over again for the rest of their lives. And that trauma gets provoked or triggered by other experiences in their lives that might not even be that distressing. So in other words, future events can provoke that trauma response. All right, but why are we talking so much about trauma? Look at the prevalence. Look at these numbers. At least 70% of adults in 25 countries around the world, including the United States and Canada, have experienced at least one traumatic event in their lives. I don't know about you, but when I first learned the statistic, I just couldn't believe it. I couldn't believe how high it was. 76% of US high school students have experienced at least one positive on the ACE, the Adverse Childhood Events Questionnaire. And I'm going to tell you a lot more about the questionnaire in the next several slides. And then 12 to 17% of adults in the US have experienced 4 or more positives on the ACE questionnaire. The references for these statistics, by the way, are on the handout that Astrid provided to you in the meeting notice. And what I want to highlight here is that given this high prevalence of trauma generally, chances are quite good that many of us in this room have experienced trauma. And it is possible that the content of my presentation could be retriggering for some of you. I will do my best to deliver this content in a productive, positive, and sensitive way. All right, here's another definition of trauma. This one is from SAMHSA, the Federal Substance Abuse and Mental Health Services Administration. Trauma is an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects. So what are these events or circumstances? So let's go back to talking about the adverse childhood events. In the late 1990s, two internists, Dr. Vincent Felitti and Dr. Robert Anda, noticed that many patients, so now they're internists, so they're treating adult patients, and most of their patients with physical ailments had a history of childhood abuse or household dysfunction. They decided to study this, and they studied more than 17,000 patients and published their reports in a paper in 1998 titled Relationship of Childhood Abuse and Household Dysfunction to Many of the Leading Causes of Death in Adults, the Adverse Childhood Experiences, or the ACE study, and that reference is in your handout. They developed a list of 10 questions that asked about abuse and household dysfunction experienced by people before the age of 18. And this list of 10 questions is called the ACE questionnaire. A positive or a yes answer to any of the 10 questions constitutes a person's ACE score. So the other thing really interesting finding is that they notice a dose-response relationship between the ACE score and the development of physical, mental, and behavioral health issues. And what this means is the higher your score on the ACE questionnaire, the greater the chances that you would develop physical, mental, and behavioral health issues. I'm going to show you the ACE questionnaire now on the next 2 slides, the first 5 questions on the next slide and the last 5 questions after that. I just want you to scan them, just read them in case you are unfamiliar with the questionnaire. So those are the first 5, here are the second 5. And so a person's ACE score is the total number of checked or positive responses. And you might find that you have some positives on this questionnaire. There has been additional research that's expanded on the original set of the ACE items to include adversities common in diverse, non-white, lower socioeconomic level communities, and also adversities perpetrated not necessarily by family members, but by peers. So, for example, bullying. This reference is also on your handout. But there's trauma in adulthood as well. Military service, abuse of various kinds, including abuse at the hands of a healthcare professional, the dissolution of a significant relationship, the loss of a loved one, in particular if that loss was unexpected, if the loved one was a child, or if it was through violent crime, accidents, institutionalized racism, and generational trauma. I don't know if you're familiar with the term generational trauma, but that's the transmission of trauma from the generation experiencing the trauma to subsequent generations. So, for example, families of survivors of the Holocaust or Japanese American internment camps, slavery, structural racism on Black people, as well as the historical trauma experienced by American Indian communities, the families of Vietnam War veterans, and others. And the trauma reactions vary by generation, but often they include shame, increased anxiety and guilt, a heightened sense of vulnerability and helplessness, low self-esteem, depression, suicidality, substance use, difficulty with relationships and attachment to others, difficulty in regulating aggression, and extreme reactivity to stress. And I just am wondering, as you heard that long list of behaviors and symptoms, if it resonated with your experience with the people you work with. Well, how does this happen? Parental communication about the event and the nature of family functioning appear to be particularly important, and they involve effects on relationship skills, personal behavior, and attitudes and beliefs. If we go back to childhood adversity, let's look at a hypothetical example of a clinician who has an ACE score of 4. So let's pretend this hypothetical clinician has experienced verbal abuse, emotional neglect, had a family member who had alcoholism, and that same family member or another family member had mental illness. This puts the clinician in a high-risk category for several things that may be instrumental in their needing the services of a PHP and may also be instrumental in any professional wrongdoing that has come to the attention of their regulator. Let's look at people who have an ACE score of 4 or more. Among the US population as a whole, these folks have likelihoods of these conditions. So, more than 1.4 times the rate of diabetes compared to folks who don't have such an ACE score. At least two times the risk of stroke, cancer, and heart disease, 3 times the risk of smoking, 3 to 4 times the risk of chronic lower respiratory disease, 5 times the rate of depression, 7 times the rate of alcoholism, 10 times the rate of so-called problematic drug use, and look at the rate of suicide attempts. Almost 40 times more a risk of suicide compared to the general population. I see, Christine, you raised your hand. I'm glad you're here. Thank you. I wonder if you wouldn't mind, can we hold questions to the end? Or put the question in the chat and we can keep track of it that way so we don't forget. If you don't mind, that would be great. Thank you. These statistics are from the UCSF Center to Advance Trauma-Informed Healthcare. So an ACE score of 4 or more might sound like a lot to you, and you might be wondering how many people that even applies to. It's estimated that 12 to 17% of adults in the US have an ACE score of 4 or more. With an adult population in this country of a little more than 260 million people, that's anywhere from 31 to 45 million people. 31 to 45 million people. And for context, the population of the state of Maryland is 6 million people. So that's a lot of people. All right, so we're going to talk now about red flags for a history of trauma. These could be traumas from childhood or adolescence or adulthood. So if you are working with people who fall into these categories, you might think about whether they also have a trauma history. So folks who are subject to bias and discrimination, maybe they are in ethnic, cultural, or religious minorities or non-native English speakers. They may identify as neurodivergent. They may identify with a gender identity or expression that is atypical or out of the mainstream. They themselves may have poor boundaries. They may have mental health issues. They may have a history of trouble with the law, and that can include DUI or intimate partner violence. I just want to say a little bit about neurodivergence. Because not everybody is familiar with that term. I mean, you may be very familiar with it. I just don't know. But since not everybody is, I wanted to spend a minute talking about it. So it's a non-medical umbrella term for people who have differences in how their brains work, leading to certain strengths and also challenges compared with so-called neurotypical people. I want you to know about this because it's pretty common, 15 to 20% of the world's population. And of particular relevance to you, certain conditions are common among people who identify as neurodivergent, and those conditions may be considered impairments necessitating the involvement of a PHP. So for example, they may also have autism or Asperger's syndrome. They may have ADHD. They may also have bipolar or obsessive compulsive disorders. Here are examples of the kinds of experiences that healthcare professionals can find traumatizing. They may feel they lack cultural safety at work. They may be experiencing bias or discrimination. There may be generational differences in identifying and labeling trauma. They may feel that they've had damage to their reputation from allegations. We cannot at all talk about trauma without talking about the pandemic we've all gone through, which was so traumatizing in so many different ways, and people are still grappling with that. And then there's also vicarious trauma. They witness terrible things, they hear distressing stories, and that can be very traumatizing to them as well. So when you're interviewing someone, remember that they likely have their own histories of trauma. Again, remember the 70% statistic, as well as the experience of vicarious trauma if their profession requires them to care for people with severe injuries or devastating illnesses or distressing experiences. But you too, as PHP staff or board members, investigators, and other staff, you're also subject to vicarious trauma dealing with such difficult topics. here's another interesting point. Exposure to ACEs may contribute to a person's desire to enter a healing profession. This has been observed in studies since the 1970s. This doesn't mean that everyone who goes into a healthcare profession has had exposure to ACEs. It means that among people who have had exposure to ACEs, many have felt drawn to entering a helping profession. This point is made in the Williams article that is referenced on your handout, and I'm going to come back to that article in just a few minutes. Okay, so how might a PHP become involved with a clinician who has a history of trauma? I've already described the elevated prevalence of mental and physical health conditions among clinicians who have a history of trauma. And some of those conditions could render them impaired, in which case they may self-refer or be referred to a PHP. In other situations, a clinician may come to the attention of their regulator because of some sort of professional violation. And there is research to suggest that ACEs play a role in professional violations. Here's that Williams study I was telling you about, again, listed on your handout, that found that physician and physician trainees, specifically medical students, with high ACE scores to be at elevated risk for boundary violations, disruptive behavior, substance use disorders, difficulty with collaboration, heightened responses to stress, and trouble benefiting from feedback. Notice the prevalence of an ACE score of 4 or more is 22%. I told you earlier that it's among the general population, it's between 12 and 17%. So look how much higher it is in medical people. I think this list of infractions will look familiar to you. Physical and mental health issues and impairments can certainly be intertwined with these kinds of professional problems. So my point here is I want to talk about what the clinician's history of trauma brings to your table. In certain ways, a history of trauma defines a person's perception of reality. And to fail to account for that is to fail to account for the person. Now, this is not to make excuses for improper professional conduct. A trauma-informed approach is not the same as being soft on a clinician. Rather, I hope to cultivate here in our conversation today, and don't worry, I will stop talking eventually so we can really have a conversation. But I want us to talk about having a better understanding of how traumatic experiences affect conduct, so that we all can do a better job with these clinicians. So put another way, this focus on the past paves the way for an improved future of safer clinical practice. So I'm so glad Christine is here. I have just a couple of slides that are really more focused on board members and staff as compared to PHP folks, although I think there are elements that are applicable to everyone here. So the question, does trauma-informed approach play a role in enforcement? I have two excerpts here on the slide from an Australian study of the experiences of licensees who have been held to account by their regulators. This paper is also referenced on your handout. The title of the paper is Virtually Daily Grief: Understanding Distress in Health Practitioners Involved in a Regulatory Complaints Process. It's very compelling reading, and I highly recommend it. Now, remember that any clinician who receives a communication from their regulator is already filled with dread even before they open the envelope or the email message. And some of them try to avoid those fears altogether by not even opening your letters or your email messages, and you may be familiar with clinicians who have done that. But even the most benign communication from a regulator can, at least momentarily, cause great distress in a clinician. All right, I want to read to you these quotations. The first one: there has been growing concern globally about the association between regulatory complaint processes and the mental health and well-being of the practitioner who is subject to a complaint. Previous research suggests that health practitioners involved in such a process can experience heightened levels of distress, anxiety, and shame, which impacts their personal lives and their families, as well as their professional identity and practice. There have also been tragic cases of practitioners involved in complaints processes who have died by suicide. It would not surprise me if some of you have heard troubling things like this from the clinicians you work with. We will talk a little bit about thoughts of suicide later, and we will also talk about the remedial course setting where these kinds of emotions, the distress, the anxiety, and the great shame, as well as suicidal thoughts, may be the only place where a clinician feels safe enough to express them. This is also from the preceding article. Elements of the complaints process that contribute to practitioner distress include poor communication. So, for example, lack of helpful or relevant information, unclear timelines, no idea of likely outcomes, the extended time to even close an investigation, and then the management of health-related concerns. The health-related concerns are most commonly mental health issues or substance use disorders. And the study found that there was not a systematic approach to identifying, prioritizing, and managing the unique risks of these practitioners. And so this might be something for you to reflect on about your own processes. So trauma-informed care, trauma-informed clinical care has been around since the 1970s. And we're going to get to what trauma-informed approach to a PHP's work by way of talking about trauma-informed clinical care. It was first introduced as a way of providing clinical care to returning Vietnam War veterans, and although not entirely widespread, many professional schools, both medical schools and schools in other healthcare fields, teach trauma-informed care to their students. Some regulators are very committed to applying a trauma-informed approach in their investigations with complainants, and they're doing a very good job with this. But what we're talking about today is applying that same trauma-informed approach model to interactions with clinicians. So adapting from the trauma-informed clinical care, the approach would be not a what's wrong with you kind of approach, but a what happened to you, more of an exploratory approach. And this approach provides a more complete picture of the clinician's situation. It illuminates the impact of trauma on their conduct. It forges more complete and effective paths for recovery, and it avoids re-traumatization. And that last point is really important because there's what's known as the 4 R's of a trauma-informed approach. The first one is to realize the widespread impact of trauma, to recognize the signs and symptoms of trauma, to respond by fully integrating knowledge about trauma into policies, procedures, and practices, and to resist re-traumatization. So as I go through this presentation, I hope you'll see that as you adopt a trauma-informed approach, you will demonstrate awareness of these 4 key underlying assumptions. But in addition to the 4 R's, we also have 6 key principles of a trauma-informed approach, and they are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. So try to imagine how aspects of your work with clinicians can demonstrate these principles, whether we're talking about the intake process or assessment or referrals, developing a management plan, case management, or advocacy, as in the case of a PHP, or investigations of clinicians, determinations about whether the standard of care has been met, and recommendations for remedial education in the case of a regulator. All right, you might be wondering if a trauma-informed approach is at odds with protecting the public. So this slide really refers mostly to a regulator, but I think the PHP folks will resonate with this as well. So primary missions of a regulator, of course, are to protect the public and also to protect the reputation of the profession, to maintain an adequate workforce, and to ensure the workforce is healthy and safe to practice. Trauma-informed regulation is an approach that assists clinicians to recover maximally so they are equipped to practice more safely in the future. Well, what do I mean by recovering maximally? That could include referral to APHP, or a formal assessment for mental health issues or physical conditions that could be attributed to a trauma history. Mandated mental health care, mandated change in practice setting, those are just some examples. It's already commonplace for boards to mandate terms and conditions for licensees with substance use disorders, which will assist them in recovering maximally. And perhaps that's a useful construct to apply in the case of clinicians with a history of trauma. So a rationale for a trauma-informed approach in PHPs and regulators, well, you want the clinician to appreciate your role in ensuring that they are safe to practice. With a trauma-informed approach, you attend to their mental and physical health, and this earns their trust. And with trust comes improved compliance. Now, remember that these clinicians are unhappy, they're possibly defensive, and they often have strong personalities and may be accustomed to being in charge and in control. Remember that fourth R, to resist re-traumatization. You want to get relevant information without causing additional trauma. So, ways of doing that: training and communication techniques for investigators or intake staff, training in a trauma-informed approach, and I'm hoping we're going to accomplish some elements of those first two bullets today. And then what's the background of the investigator? Is it law enforcement or clinical? I'll talk about the differences between those in a little bit. So you might be wondering, okay, well, how do I even learn if somebody has a trauma history? Well, you might have a suspicion by the way they answer questions and respond to a request for information. You may gain clues from documentation that has been submitted from treatment providers. There may have been a board-mandated fitness to practice or mental health evaluation. The expert opinion. Now, the expert witness for the board especially has access to everything, including sources of information that you might not have. So they're in a great position to notice red flags. The remediation class. Now, a remediation course provider can only share relevant trauma information in a formal evaluation letter, but that would have to be with the permission of the clinician taking the course. I know the Maryland PHP prefers to receive these evaluations, and it's certainly a good practice to check with the course provider about whether an evaluation letter can be provided, and if so, what kind of information will be included. If sensitive information comes out during the course that cannot be shared, there are still ways of safeguarding the clinician's future conduct, and I'll explain that later when we talk more about the remedial courses. But then just look at that last bullet. Sometimes you just don't know. This is a common question. Should you screen with the ACE questionnaire? And the answer is no. The ACE questionnaire was designed to research the relationship between childhood adversities and health and social outcomes. Now, it could possibly be used as a screen by mental health professionals who understand its limitations. So if you suspect a history of trauma, you could refer someone for a formal evaluation. But if you were to require the ACE questionnaire, I think the clinician would perceive this as intrusive, and they may not believe that it is in their best interest to answer truthfully. So here are some goals for, oh, that's funny, the border of the slide is off. Well, I hope you can still see that okay. Goals for intake interviews and assessments in case management, advocacy, and regulatory processes. Try to minimize or avoid fear, anxiety, stress, and uncertainty, perceptions of unfairness, clinician avoidance or lack of engagement, overly legal processes, and forgetting there's a real person on the other side of the table. And I'll share with you some strategies or tips for trying to minimize or avoid these things. Here's some guidance for more productive interactions. You want to build a relationship. So your approach should be fair and kind. Try to be as flexible and accommodating as you can be in terms of the time or the place of your conversation or your interview with the clinician. Monitor yourself for internal biases and assumptions. Um, and try to convey respect. This can be really hard if what the clinician has done or is accused of having done, or if what they're suffering from is triggering for you. And then be aware of the balance of power. So what do I mean by that? You want to try to gain information and facts without judgment and bias. You want to have kind of an even exchange as much as you can. So many of these items might relate more to the work of a board than a PHP, but I still think a lot of this will resonate with your experience. So think about gaining information or doing the intake. It's more of an interview or a conversation, rather certainly than an interrogation. You may wish to get a written statement from the clinician. Now, some Indigenous groups prefer to dictate their story to somebody else rather than write it themselves. So it's helpful if you have the flexibility to accommodate that, as well as for clinicians who are not very facile with a computer. You may have access to patient records or police reports or court records, reports from treating providers. You may need to visit the physical space of where they practice. You may need to ask them to demonstrate some clinical techniques. And consider the location, the date, and the type of interview you're going to have with them. It's important, and this gets back to the power imbalance, to give the clinician as much control as you can, so that the power dynamic between the two of you doesn't unduly affect their cooperation. So see if you can let them pick the location and the date of the interview, or even whether it's in person or virtual. All right. Let's get to some practical approaches. I mentioned that a few slides ago. I would have some tips for you. So that's what this section is all about. There are challenges in working with clinicians who have a trauma history. They may feel very frustrating to work with. They may appear to be uncooperative. Their responses to future events that evoke the traumatic experience may appear irrational to you. They may make others feel helpless. They may make you feel helpless. And their interactions with a regulator or even with you at a PHP can potentially be re-traumatizing. So I imagine you've experienced this. Course providers and faculty experience this as well. So here are some ideas for an approach. I've already alluded to this. Set the stage for a confidential, trustworthy conversation. Most of the tips I'm going to talk to you about over the next several slides will work for both in-person and virtual conversations with clinicians, although you'll see that some will work a little better for one setting or another, or the other. I'll also say to you that some of these tips may sound very simplistic, but even simplistic things can go a long way to developing rapport and engagement. So ask them what their preferred name or nickname is. And if the name is difficult for you, ask them how to pronounce it, write it out phonetically, and include the correct pronunciation in the file so that you'll be reminded the next time you talk to them, or so that others who may need to talk to them will see it as well. Try to avoid making assumptions about their gender or sexuality. And this includes assumptions you might make based on their appearance or their name or their voice, especially if you're talking to them over the phone or you're listening to a voicemail message they may have left for you. Okay, pronouns. Now, this might be hard for some of you. Use their preferred pronouns. Indication of preferred pronouns should be included as a basic part of demographic information. When talking about individuals that you don't know, try to get in the habit of using they rather than he or she. This might feel awkward at first, but it can become second nature quickly. And by the way, this is not some new woke or PC vocabulary. They has been used as a gender-neutral singular pronoun for more than 600 years. If you happen to use the wrong pronoun, simply acknowledge your mistake, apologize, and move on. Racial assumptions. Avoid making assumptions based on a person's skin color, facial features, or hair texture. Some people appear to have very light skin or other features consistent with a white race, but they in fact may not be white. And be aware that some ethnic or cultural groups or genders may not feel they can speak up or have the right to. They may feel it's not their place or may have received messages over time that it's not their place. This may come across to you as resistance when it actually may not be resistance. If you suspect this is going on, you could specifically invite them to ask questions. So for example, you can let them know that most clinicians in their situation will have questions. And then they then say something along the lines of, some people have been discouraged from asking questions in the past, especially of an authority figure. But I hope you know that I want you to ask about anything that you might have on your mind. Also remember that in most instances, you are going to be having a conversation with an unhappy person. So prepare yourself. What are your expectations and your feelings walking into the conversation or the interview? There's an expression, name it to tame it, and I love this technique. What it involves is you inventory your feelings before you walk into the appointment or the interview. And you just go down a laundry list. And maybe your feelings are about the fact that traffic was terrible on the way into the office that day, or somebody at home spilled or made a mess or something, and you're really aggravated, or you're running late, or whatever it is. Or you are thinking about this interview and you don't happen to really like this clinician very much, or you're struggling with them and you don't really know how to deal with them or how to get through to them. If you go through that inventory of your feelings and you say to yourself exactly what's bothering you, you are now attaching language onto an emotion. And you're taking the emotion out of the emotion center in the amygdala in your brain. You're putting it into the prefrontal cortex, which is your executive functioning, which is where you have the power of language. And now you are able to demonstrate control over yourself. And you can say, okay, such and such happened. I need to leave that at the door. This is how I'm feeling about this interaction. And it's really interesting what happens. You feel a lot more in control over the situation. It's a great little technique, which I recommend highly. Also, when you're having a conversation with somebody like this, do you have prior experience with them? And does that experience color the interaction you're about to have with them? If you're not exactly sure what you're going to say or how you're going to say it, practice out loud. You might even want to practice in front of a mirror. All of those will render you a lot more prepared for the interview or the conversation. Now, this applies to both in-person and virtual meetings. Create a safe space. So consider the location. Is it on your turf or on their turf? What's the time of day? Are you looking at your watch because you have another meeting to get to? Are they looking at their watch because they have to get back into the office? Is there a lot of office traffic? Is that going to be noisy? Make sure you have a private and a confidential space. Make sure your appearance is professional, and especially if it's virtual, make sure your background is professional. And by all means, stay calm. This is why you need to stay calm, because ignoring the heat in the room does not lower the temperature. And people in the throes of intense emotion are unable to process information. So you want to frame the conversation. Just get right to the point, get to the bottom line, whether it's positive, neutral, or negative. Don't have a lot of silly kind of superficial chit chat at the beginning, because then the clinician might interpret that as you're being manipulative or untrustworthy. You don't have to be cold, though. I don't mean that either. You can say, thank you for meeting me. Thank you for taking time out of your day to have this meeting. Be aware of your tone of voice, the language you use, and the tempo of your speech to make sure that it matches the content of what you're saying. So you don't want to rush through something that is really important. You really want to have the right tempo to match what you're talking about. And then simply convey information. Avoid trying to be their friend or coming across as judgmental. You simply have a job to do. Also assure them that you are going to consistently apply the rules and the processes to them just the way you would to anyone else in a similar situation. All right, I mentioned a little earlier the difference between whether somebody has a background in law enforcement or clinical work. And that we're going to get to in this slide. So here's an example of how a trauma-informed approach can result in better information and an experience that does not traumatize the clinician. I'm sure it's been your experience that most clinicians who commit some sort of professional wrongdoing or who have some sort of impairment are otherwise worthwhile members of their profession. And true, they must be held accountable. They may require extensive remediation and monitoring, but they may merit a second chance with appropriate safeguards. So using an interview or conversational approach rather than an interrogation approach may be instrumental in achieving their buy-in to the process, inspiring their compliance, and accomplishing a more successful remediation and rehabilitation and safe return to the workforce. So you see here on this slide a comparison between sort of an old-fashioned interrogation technique, which is a little more aggressive, might use deception. The read technique is the thing that would be familiar to folks who may have a law enforcement background. It's known for creating a high-pressure environment for the interviewee. It's been criticized for resulting in high rates of false confessions. Now, please don't think that I am critical of investigators who have come from a law enforcement background. I am not. The points on this slide, interestingly, come from health regulators in other states who do have a background in law enforcement and who have learned that the interview approach, rather than the interrogation approach, is more productive in the setting of professional regulation and well-being. And so you see the conversational, the interview approach builds rapport, establishes trust. It seems to be more ethical, it's open, it's collaborative, that sort of thing. Here are a couple of ideas that illustrate a non-judgmental, safe, and trustworthy environment for information gathering from clinicians. So the questions to avoid are asking for clarification of what happened, which could be perceived as faulting the clinician for taking or not taking certain action. And even if it is their fault and they committed some very serious wrongdoing, asking questions in this way can put them on the defensive and make them less willing to be forthcoming. Instead, asking the clinician about their thought process and experience gives them an opportunity to explain what they did or did not do and why. So the use of "are you able to" reduces the pressure on the understandably very nervous, self-conscious, and potentially quite guarded clinician to more fully articulate what they did and why they did or did not act in a certain way. And their responses might lead to a recognition of underlying issues, such as those that evoke prior experiences of discrimination, injustice, or trauma that may have been at the root of their professional wrongdoing or their impairment. Now, in some situations, you might want to make one or both of these points, which again should make the clinician feel more comfortable and forthcoming. One point is that every licensed health professional has the potential to commit a violation. They are not monsters. They are smart, well-educated, usually law-abiding and well-meaning clinicians who, for a variety of reasons, caused or could have caused significant harm. And then the other point is that perception matters. So they may have had good intentions or thought they had good intentions, or they may have believed that whatever their issue is, as long as no patients were harmed, then it was probably okay. But as trusted representatives of their profession, perceptions matter. So here are some more practical communication approaches. Show respect without condoning. You don't have to condone what they've done, but you can still show them some respect. So don't interrupt them. Your attentiveness will build trust. So how might you do that? Here's the 8-second rule, which means if you're about to say something, just stop. Don't say anything for 8 seconds. Okay, it could be 7, it could be 9, it could be 10. Count to something. The point is, if you feel like you're about to open your mouth, don't do it. Open your ears instead. Pauses are your friend. They create time and space for the clinician to say more. This further demonstrates respect, and if they feel respected, they are more likely to comply with your processes. And having them explain more helps them name and tame their emotions. A corollary to the 8-second rule is the acronym WAIT, which is why am I talking? If you are an interrupter, you might want to remember the acronym WAIT. Okay, other practical approaches. You could say something like, I can see you are surprised or upset or frustrated or confused, whatever it is. Help me understand why you feel this way. Trying to calm someone without really listening comes across as condescending and disrespectful. You might feel a trigger or vicarious trauma that affects your ability to stay in the moment. When your frustration or anxiety intensifies, then your ability to listen and process what you are hearing decreases. And strong emotions are transferable. Be aware of whether you are absorbing the clinician's agitation and telegraphing it, or telegraphing your own agitation onto the clinician. Remember, the clinician may have taken a very big hit to an important part of their identity. They may feel aggrieved, they may be accustomed to being in charge, and despite their professional accomplishments, they may feel embarrassed, angry, defensive, and shameful. Now, if the clinician gets angry in your conversation with them, do your best to respond calmly. Stay safe by all means. If you need to, leave the room. Ask them if they wish to take a break. And if they do want to take a break, you could resume the conversation after a few minutes or at another time. Establish boundaries. You could say something like, you are entitled to your feelings, but this conversation can only be conducted when everyone feels calm. And notice here it says everyone feels calm. It doesn't say when you feel calm, because you don't want them to feel like you're pointing a finger at them. You want them to realize that you need to stay calm too, that you're in this together. Here's another approach that might smooth out the power dynamic in the room. Try some compassion for them. This may be all they need. They may simply want to be heard. And your compassion could be disarming. It could increase their cooperation and remediation potential. I have the permission to share with you a quotation from one of our course participants about this point. They said, the disciplinary process was so dehumanizing. It was hard to cooperate when I felt dehumanized. Now, trying some compassion for them, though, might be difficult for you if their conduct is egregious or triggering for you. So watch your facial expressions that might indicate you're feeling judgmental about these clinicians, even though your words might be neutral or even compassionate. And then in your subsequent communication with them, try to avoid mailing letters on Fridays or before major holidays, or even if it's an email message, because they'll receive something from you and not be able to respond, not be able to contact you and talk about it or get a question answered until the weekend is passed or the holiday is passed. They might be sitting with information that they feel is very distressing over time. And that's really needless anxiety and worry for them. Avoid sending email messages before you will be out of the office for an extended period of time. It's kind of for the same reason. Unless you have a colleague you can refer them to in your absence who can address the issues as well as you can. And then you could consider phone-only communication. And I put that on the slide because there are some regulators that do take this approach. It's not perfect, but it is quite personal, I have to say. It is really far more personal than sending something through the mail or an email message. Alternatively, and this is something that some other entities do, you could give them a phone call first before sending them a letter. It's, in a sense, I guess, kind of a trigger warning. So you could call them up and say, hello, this is so-and-so from the PHP. I know we've spoken before. Just want to let you know we're going to be sending you something in the mail, and I want you to read it over, and you might have some questions. And if you do, please give me a call in a few days, and we'll talk about whatever questions you have. So at least that prepares them, and your open approach will not have their pulse race, I hope. They know that they can expect something from you and then deal with it with you at a later date. Now, I talked about suicide earlier in the context of that Australia paper, and I told you we were going to come back to it. And so we'll come back to it again later as well, but here we need to talk about it specifically. You may already have good processes for this, and in which case, if you have good processes, you don't really need what I'm telling you here. But in case you don't, or you want to consider something else, the general point of this slide is if someone talks about suicide, do not ignore it. You could respond with, so you have had thoughts of suicide. Can you tell me more about how you came to have those thoughts? Have you told anyone else about this? Is there anyone you can talk to about this? And then say, I would like you to get adequate support, so I need to convey what you have told me to so-and-so, whoever it is. Your executive director, the person next up on the chain of command, whoever it is. Don't worry, we will respect your privacy, but we are concerned about your continued well-being. Don't do your own risk assessment unless you are specifically trained to do that. So if you don't have that training, don't do it. If you do, then fine. But risk assessment and psychiatric diagnosis might not be your jobs, but communicating this information is your responsibility. So if you need to tell a supervisor or executive director or someone along those lines, the preferred language to use, you may already know this, though, is person first language. So-and-so is thinking of suicide, or so-and-so has experienced or suffered through suicidal thoughts, rather than so-and-so is suicidal. And this avoids defining someone by their experience. It's also possible that suicide is an issue you might be familiar with, either personally or professionally. And if that is true, you may wish to keep that private. But then do what you need to do to process the conversation with the clinician with the suicidal thoughts. And this will help you avoid being re-traumatized by the subject matter. You might even consider asking to be taken off their case. I don't have separate slides on this, but you can also take a similar approach if a clinician tells you about having mental health issues or substance use. And this is critically important information that must be attended to because a healthy clinician will practice safely, and you are in the business of supporting their well-being. Now, a little bit about care for yourselves. If the waters become choppy in your work or in your conversations, you can calm the waters by identifying what you are feeling, again, the name it to tame it technique, using the snow globe technique. Now, what is that? I think you all know what a snow globe is, the little glass sphere. It's got liquid inside and a cute little scene or a person or something, and then the glitter or the snow, and you turn it upside down, you turn it right side over, and you look at the pretty little scene. Pretend you and the clinician having the conversation are in that snow globe. And so while you're having the conversation with them, you're watching yourself at the same time. Some people use the technique of pretending you're watching yourself on a video camera. It's the same concept. It provides a bit of cognitive dissonance, or not dissonance, sorry, not dissonance, cognitive distance so you can participate and analyze at the same time. Again, a little bit of distance keeps you in a little more control. And try to avoid an authoritarian approach. Because an authoritarian approach, even though you are in the position of power, might trigger defensiveness or a power struggle with the clinician. If the conversation escalates, have an exit strategy. Now, I call this an uncomfortableness scale, and this is a threshold for action. You create your own uncomfortableness scale. At the low end, for example, you might feel mildly annoyed, then displeased, then offended, and then upset at the upper end. Or you might tie it not to your emotions, but to physical sensations. So for example, you might have a little bit of jaw clenching, and then you might have fist clenching, and then you might have abdominal tightness, and then you might have heart pounding. So choose your threshold for ending the conversation or meeting. Don't let yourself get to the far end of your uncomfortableness scale before you make a move. If you are starting to feel uncomfortable, you can take a mini timeout. Simply say, please excuse me for a moment. You don't have to provide a reason. Then go to the bathroom, get a glass of water, blow off steam with a colleague, but really just take a few moments. I mean, don't take a half hour, but if that's all you need to kind of break the emotional connection of what's going on, give yourself a little distance. You may need to go up the chain of command, get a little assistance or some ideas about how to handle the situation a little differently, or memorize some brief scripts. I am a huge fan of memorizing brief scripts because these prevent you from having to search for words in the heat of the moment. You come up with a brief script and you memorize it. If you're doing a virtual meeting with somebody, you can even have them written out on your desk, so you don't even have to worry about relying on your memory. But something like, this does not seem to be a good time to continue this conversation. Or, I'm really sorry, but I'm not going to be able to complete this call right now. And then you make a plan for rescheduling or resuming. But notice in those two examples I gave you, no reason was given. You don't have to give a reason. You don't have to point a finger at them or at yourself. You're in charge, and you simply say, this needs to end right now. Don't worry, we'll finish up later, but it just needs to end right now. Now, if the conversation is ended, documentation is like professional self-care. So you write down what transpired, use as much verbatim language as you can remember, write down what actions were committed to, and then whatever follow-up communication to the clinician with next steps. And afterwards, debrief. You can do this all by yourself. What worked well, what didn't go so well, so you can use it for future reference, or you can debrief with colleagues. And finally, try some compassion for yourself. Now, what is self-compassion? It is not the same as self-pity or complacency or having good sleep or diet or exercise habits. Self-compassion is a healthy way of relating to yourself when you're faced with difficulties or distress, and it has three components. You recognize our common humanity, and by that I mean feelings of inadequacy or frustration are part of the human experience. The second component is mindfulness. So don't ignore the pain or the distress, but don't engage in self-criticism. And then the third component is self-kindness. So treat yourself as a friend would treat you. You don't suppress, but you also don't exaggerate your feelings. You say to yourself, okay, didn't go as well as I thought it would, or I didn't do as well as I thought I could. I want to do better next time. This is not the end of the world. I have learned from the experience. I will do my best next time. So that's what self-compassion looks like. Okay, I'm looking at the clock. We've been at this for a little more than an hour, and I really appreciate your attention. And I'm getting close to the end so that we can talk. So my last section is about remedial education. And that is, again, as I told you at the beginning, that's what I do. That's what we do at PBI. So think back to about 45 minutes ago, maybe more, when I described adverse childhood experiences and the ACE questionnaire. Well, clinicians working in that space recognize that developing some foundational skills could help children recover from trauma and avoid re-traumatization, so they could be healthier and more productive going forward. And those foundational skills are attachment, stress management, and self-regulation. But those skills work for adults too. So on the next slide, I'm going to tell you a little bit about remedial courses, a fuller description of what remedial courses do and how they work. That's outside the scope of what we're talking about today. If any of you are interested, I'm more than happy to talk to you about it at another time or during the Q&A at the end. So as I mentioned earlier, it may be that the clinician's history of trauma does not come out until they participate in a remedial course. And if not for the remedial course environment, information on trauma and perhaps misdirected attempts at self-healing may never be discovered. So just so you know, there are several reputable providers of remedial courses out there, and PBI Education is just one of them. There are similarities in the way that most of us do things, so to a certain extent, what I'll be explaining to you will be true for the others. But I will be using PBI's method as a case example, and anything I show you that's unique to us, I will tell you that it's unique to us. There are features of the remedial course experience that can demonstrate most of those 6 key principles of a trauma-informed approach that I shared with you at the very beginning: the safety, trustworthiness, peer support, collaboration, empowerment, and cultural, historical, and gender issues. And those features involve the work and conduct of the remedial course staff and faculty, as well as the structure of the courses themselves. So let's start with the staff. We conducted an in-service on diversity, equity, inclusion, and belonging, plus trauma language and a sensitive approach. We see a connection between DEIB awareness and the use of sensitive language and a trauma-informed approach, because being discriminated against or made to feel like you don't belong can themselves be traumatizing experiences. We conducted another in-service on dealing with folks who may come across as difficult, and that may be the reason why they are sent to a course in the first place. And that in-service included things like the practical tips I just shared with you, setting the stage for what could be a difficult conversation, timing, privacy, confidentiality, dealing with your own emotions of stress, distress, or vicarious trauma, or re-traumatization. Now, when we talk about training our staff, the remedial course experience begins with not only with the actual course itself, but actually with the clinician's first outreach to the course provider. And that simply could be their preliminary inquiry call. So the staff person may be the first one they interact with, and that could simply be over the phone. Since the pandemic happened, we and most other remedial course providers have transitioned to offering our courses in real time, but through a virtual platform. So just like this, just over Zoom. We schedule technology checkpoints in advance to make sure the course participants are comfortable with the technology requirements and they're familiar with our policies and procedures. But course participants are not the only people that the course provider staff interact with. They also interact with you, so PHPs, regulators, and other referring entities who may have your own trauma history or may be re-traumatized or vicariously traumatized by the investigation process or investigation findings and the nature of certain infractions. Before I go into course faculty skills, let me tell you just a little bit about how intensive remedial courses work, as some of you might be unfamiliar with them. So remedial courses are quite unlike other continuing education courses in several ways. They are small group classes, so 10 to 15 people. They are very interactive. And the interactive nature cultivates collaboration. The course participants learn from each other's experiences and they cultivate peer support. There are designated faculty that teach the entire course, so they get to observe the development of insight and the development of growth over the duration of the course, or they get to observe the lack thereof. That's also important. There are strict confidentiality policies. The setting must be private, and the faculty do a lot to establish a safe learning environment. All right, the content of this slide is unique to PBI, and I'll explain it in a minute. Our trauma-informed approach is meant to cultivate restorative justice. Well, what are we trying to restore? It might not be possible to restore a damaged relationship between a clinician and a patient who has been harmed or felt harmed, but we can certainly aim to restore the clinician's commitment to professional ideals that they can demonstrate with future patients, should they be allowed to continue to practice. And there are many reasons why clinicians become distanced from that commitment. After having been held to account for professional wrongdoing, they might undergo what I sometimes call transformative justice. And I use that term because I certainly have witnessed this in our remedial courses. So the funny looking figure on the slide is what we call the formula. And it is PBI's way of depicting the complex but very common interplay of all sorts of elements in a person's life and work that can cause them to commit some sort of professional misdeed. Now, we could talk for an hour just about how the formula works. We're not going to do that. But for our purposes right now, I just want to say a few things. So first, RF. That stands for risk factors. And those are features of a clinician's profession or professional life that can heighten their risk of committing a violation. So for example, solo practice or professional isolation. The VUL stands for vulnerabilities, and those are features of the person. So a trauma history is relevant here. How that trauma history gets played out in someone's professional life might, for example, cause them to have boundary problems, become a bully, or develop an addiction. A lack of adequate accountability measures, that's the capital letter A. Demonstrations of resistance, that's the lowercase r. And finally, the presence of a catalyst, that's the C at the circular arrow, which could be a crisis or a loss or another kind of trigger. All of those things propel a clinician to commit a professional violation. So you can see that we dig below the surface in our courses, and it's not surprising that in this setting where a participant's history of trauma may come out. Remember that 70% statistic. Chances are good that trauma is a factor for most of our course participants. Now, the last bullet on this slide, the plan of action or the personalized protection plan, might actually be the most important point on the slide. It is also unique to PBI, although some other course providers have something similar. And this is a plan that each participant is required to develop in the course in order to graduate. It is tailored to their specific situation and infraction. And remember that if it is the case that it might not be until the remedial course that a clinician's history of trauma comes out, this is not information the course provider can share with the referring entity in the post-course report that we provide. But the course faculty can make sure that the participant's plan of action includes steps that will help the participant deal with their trauma, improve their self-care, learn self-advocacy, work on healing, and choose safer practice settings. Perhaps participants learn that addressing their wounds will facilitate their return to safe practice. So let me describe some of the skills that faculty need to possess in order to teach remedial courses. We also gave them an in-service on sensitivity and language, DEIB, and language and other things, as we did with the staff. In our faculty meetings, which we have several times a year, we discuss ways of diffusing anger and resentment and how to work with folks who are resistant to the process. There are lots of ways that faculty can be sensitive to the accidental triggering by others. So they reinforce the safe and supportive educational learning environment. The faculty already know why participants are there. They know that in advance, both from the perspective of the participant, but also from the referring entity. And so if one participant has a history of trauma that could be triggered by another participant's story, the faculty can explicitly acknowledge that and state it's okay to step away if need be. Faculty must have a high index of suspicion for indications of past trauma in participants who have boundary violations, disruptive behavior, and substance use disorders. This harkens back to the Williams paper I told you about 45 minutes ago. And then faculty use all these skills not only in the intensive seminars, but also in that longitudinal follow-up course that we offer that keeps clinicians connected and continues the healing process. There are some additional faculty skills. They need to engender openness to remediation, and they do that through compassion and sensitivity and an educational approach. So it's not a punitive, but it's a restorative learning environment. And the use of sensitive paced questioning is an approach that creates an environment where participants disclose their feelings of shame, remorse, and regret for what they have done, or how they have failed their patients, their professions, and others. And this is a setting in which some course participants express having had thoughts of suicide. Again, if not for the remedial course, this information may not ever come to light. Course faculty also realize that many participants may have a trauma history, even if they don't share it. And then, as I alluded to earlier, there is that small body of literature that demonstrates a connection between a history of ACEs and a person's desire to enter a healing profession. In short, there are lots of ways that faculty can recognize the signs and symptoms of a trauma history, which is the second R in those 4 Rs I told you about. Okay, so in conclusion, a trauma-informed approach does protect the public by demonstrating attention to circumstances and histories that may render clinicians more vulnerable to recidivism, and by identifying more impactful ways of accomplishing professional rehabilitation and recidivism prevention. So it allows otherwise capable, valuable clinicians to remain in the workforce. And we have good reason to believe that a trauma-informed approach would reduce recidivism because of the excellent results of taking a trauma-informed approach in the criminal justice system, particularly in the realm of intimate partner violence. And there are some references about this on your handout as well. You still might be wondering whether a trauma-informed approach would be a more lenient approach. But I want you to consider how a trauma-informed approach could cause you to look even closer and conduct more complete intakes, assessments, and investigations, make more appropriate referrals, and develop more impactful management plans. Okay, your jobs are complex and difficult, and I don't mean to give you more to do. But here are some ideas that are fairly easy and simple that you might even be able to implement on Monday. You can find some guidance and resources about these on the handout. Things like addressing the communication skills of your staff, including the folks who answer the phone. Researching training for board members or staff, reviewing your website, making sure it's welcoming and it's clear what information is confidential and whether FAQs are written sensitively. So those are just a few examples. And that's all I had prepared for this, the formal part of the presentation.